How do we engage in establishing boundaries, whether they are physical, mental, emotional, financial, related to resources, spiritual? And for you to think about, how do you set boundaries? What are your boundaries? What are the methods that you most utilize to actually set boundaries with people in your life? And very specifically, because this is pertaining to all of us as healthcare providers, how do you set boundaries and what methods do you use in healthcare? Boundaries are good. They're necessary. They are required for a number of things: to keep you safe, to keep your patients safe, to keep your colleagues safe. Because if you have wishy-washy boundaries, and then you go off and your colleague comes on, and that is a potentially unsafe, mentally, emotionally, physically, spiritually unsafe situation for them, you have the potential of setting them up. So our boundaries are important, they're good, and it's also really good for us to know what they are, not just for ourselves, but also the way in which they affect other people that we work with too. Our boundaries are, we talk about them as a positive thing in healthcare, partly also from an ethics perspective. That if, crossing one's boundaries, professional boundaries, whether it's related to sexual misconduct or gifts or favors or misusing personal resources like cell phones for family members to call you and give you updates or ask advice, those are some real clear violations. And you'll see one of those videos that's produced for nurses. And most of you will maybe have even seen those things, in terms of ethics or onboarding videos about don't touch your patients inappropriately, and in a sexual manner. Okay, cool. Yes, don't do that. I would not like anyone to cross any of those boundaries. But most of the boundaries that get crossed for us are subtle. And they're not always getting crossed by our patients. They are getting crossed by our colleagues. They're getting crossed by our supervisors. They're getting crossed by the institutions in which we are employed. And that then those boundary crossings trickle down to our colleagues and supervisors who may not necessarily be comfortable with those boundary transgressions, but engage in them anyway, because that's the way that the company works, so to speak. So there are a lot of ways in which we interact with them, and a lot of ways in which our own boundaries, even when we know them, get crossed. And so this whole enterprise is intended for us to look at the whole picture. I want you to think about what your boundaries are personally. I want you to think about what your boundaries are professionally. And I really want you to think about this week where your boundaries get crossed on a regular basis and by whom they get crossed. Is it coworkers? Is it patients? Is it supervisors? Is it the institution? Is it all of the above? Maybe even make a list, catalog it. Be aware of how many times this happens to you. Because, and this is really important, is that the more often that our boundaries get crossed, the more often that we feel powerless in those situations to advocate for either placing, replacing, or maintaining our boundaries, we then transfer that powerlessness to other people. And this is really critical for us to be reflective about, to understand, and hopefully be preventive. In terms of a behavior to engage in. We don't want to transfer that powerlessness to our patient care dynamic. And as I mentioned last week and the week before, the patient care dynamic is inherently a power dynamic. Every time you walk in that room as a healthcare provider, you walk in as a representative of the company, so to speak, of the larger group, of the people who have expertise, as the person who has expertise. Literally very often from a physical standpoint as the person who has physical power if your patient is restrained, either chemically or physically. If the person has IV tubing in and leads for an EKG and a urine catheter in, they are restrained possibly not by formal restraints, but definitely by all of the other things that are inherent in medical care. Patients laying, on their back or reclined in the bed while you stand. There are a number of ways that we communicate power to our patients, and there is some benefit to that, right? I mean, we need them to see us on some level as people who have something to offer, And for some people, for some patients, that's really beneficial. They need to see you as bigger than them, better than them, more, more expert, smarter than them in order to feel cared for by you, in order to feel safe. And for other people, that is exactly the thing that contributes to their lack of safety in your care. Not everybody thinks that sitting down next to them at the bedside and having communication, peer to peer is communicate safety, right? Not everybody actually feels that way because they need to feel like you know more than them, that you're better than them on some level in order to feel safe in your care, in order to submit to that care. How can you know who those people are? You don't, right? You really don't. The key is for us to be reflective about it, to be aware of it, and to walk into every situation saying, this is inherently a power dynamic. Does this power dynamic work for these people, for this person, this family, this patient, or does it not? And how can I find that out quickly? And ask. A lot of it is ask. And, how do you feel here in our care? In this, how would you like to be communicated with? Patients don't always have a very clear answer of like, how do you view the healthcare paradigm from a power dynamic? But they do have a sense of how they like to be communicated with. You can ask really simply. But when we are in those power dynamics, if we are continually made to feel powerless, well, inside that room, but everywhere else outside that room, we will bring that powerlessness and that frustration with that powerlessness into that interaction with those patients. And it is normal, actually normal, and expected on some level that we will transfer that powerlessness to our patients. That like, these people out here are making me feel real powerless. They're constantly, in my space, over my boundaries, asking me to do things that are not okay, that are unethical, that are unsafe, maybe. And then I come in here, and this is the place that I have power. Now, when I say normal, I mean normal as in like it is a normal human reaction. But I don't want to normalize it in that we don't want to perpetuate that behavior. We don't want to perpetuate a behavior. We take our poor treatment elsewhere and bring that into the room and then treat other people poorly. As human beings, we do that. We see this worldwide, right? Someone talked meanly to us that day. We had a really crappy morning trying to get our kids off to school. We get in the car, somebody cuts us off, we start cussing. I'm from New Jersey, I do that a lot. We transfer our frustration and our powerlessness without even thinking about it all day long. We have a really rough day at work, we come back, we transfer it back to our family and our kids. The key is, how do we stop that behavior? It's awareness. Sometimes it is literally, there are no skills involved. It is literally the self-reflection and the awareness. So a big piece of this week's work is for you to be aware of your boundaries, personal, professional. How often they get crossed in a day. Shoot, even just keep like a little tally mark on a notebook, on your hand, wherever it is. I won't encourage you to write on walls, but sure. Mark it down somewhere how often it happens that you were put in a position where you are asked to do something that goes against your physical, mental, emotional safety, your ethics, your values, and morals are a tough one here because there are certain beliefs that some of us have that are personal, that don't necessarily have a place in our professional worlds. So I really want you as much as possible to keep this from a professional standpoint. When you as healthcare professional, nursing professional, how often do your boundaries get crossed? And then think about, if you can catch yourself, how often you bring that into your patient interactions. How often you might actually be crossing someone else's boundaries, exploiting that power dynamic with your patients. That's part one. We'll get into what happens when you do that for the patients more so in part two, and give you more information on that and give you more scenarios where we can describe that with the material that's going to come up later this week and next week. But what does this have to do with ACEs and trauma? Is where I want to tie this into last week's materials, just to kind of keep everything, layering on top of the next. So now imagine you have your own ACEs and trauma. So I've asked you to reflect on that. And as much as we say, check your stuff at the door, leave your baggage at home, there's lots of sayings about what we're supposed to do. That's part of boundaries also, right? It's not just about keeping, stuff out. It's also about keeping our stuff in that doesn't belong in that professional interaction. We also bring those into our interactions, and those also contribute to our sense of powerlessness in a situation. So when we have experienced ACEs and trauma of our own, whether they are medically induced or elsewhere, it is possible that we operate with some level of powerlessness, even before the boundary transgressions happen. And then our professional boundary transgressions happen, and that layers on top of our own ACEs and trauma. Do we put those all in? Do we keep those inside the boundaries before we interact with patients or not? Not always. So sometimes our stuff, the boundary transgressions and our own ACEs and trauma, trickle into the room. Now think about your patients. Think about the fact that they have their own ACEs and trauma. So you have learned a little bit about what qualifies as those things. A lot of things. Most people have at least one of those ACEs. And honestly, if you're working in acute care, emergent care, you're working with addiction, you're working with anybody who has mental, emotional challenges, behavioral challenges, people are going to have 2, 3, 4 ACEs. A significant amount of, if not toxic stress type trauma, at least severe, even if it's isolated incident trauma. And then there's the power dynamic. And then there's the boundary transgression. So something simple like, hey, I really care about you and I would love an update. Here's my cell phone number. Call me when you get discharged and let me know how things turn out for you. That might seem really kind, right? For some of you. I think that most of you probably get that, that would be an ethical violation for most of us. Different from my work, right? I've been in private practice for a long time. I'm a midwife. Thousands of people have my cell phone number. They don't use it because I'm real clear about what that's for. But it would be an ethical violation for you to do that, right? But aside from that, and what the institution says and what the rules are, think about how that kind of scenario can affect someone and their outcomes. When we look at the layers, it's not just the action itself. It's never just the boundary transgression. You are also, there's a layer underneath that of the inherent power dynamic. And then there is the layers underneath that power dynamic before they ever walked into that space to receive medical care of their own ACEs and trauma. Because ACEs and trauma inherently involve boundary transgressions, major ones. Physical, mental, emotional, spiritual, and repeated. That is actually what creates the trauma for a lot of people. So part of being trauma-informed providers is to acknowledge that almost everybody we're dealing with has experienced trauma, and that we can be re-traumatizing them in our actions. And it doesn't necessarily have to be a very clear and obvious transgression, like a very overt racist comment, or a very obvious bias or discrimination against someone who is transgender, or a very obvious disdain for someone who comes in for the 4th time that week and they are an IV drug user. It doesn't have to be something as obvious as that. It could be something that actually you think communicates kindness, compassion, and safety, but it can actually feel incredibly unsafe. What do you mean? They're coming in thinking that you are a medical expert and with their own ACEs and trauma, and here you are kind of almost intruding into their personal space. Think about things like our own body language, and that sometimes very, I don't want to say touchy-feely because again, there's rules around that, but very caring body language, where we get physically closer to people, can feel incredibly unsafe to people who've experienced physical violence. That even really subtle boundary transgressions can be something that can actually be part of that re-traumatization process and can actually contribute to more ACEs and more trauma for that person. It makes it very complicated, right? Boundaries are not that simple. They are, in fact, very subtle most of the time. So that's why first I want you to play around with your own. How often does this happen? Because then it makes it a lot easier to think about, God, how often do we do this to patients? How does it affect them? Well, it's very obvious that we discriminate against someone for their skin color or their sex or their gender, their religion in our space. It seems much more obvious about how that's going to affect their care. They're going to feel excluded by us. They're going to feel uncared for by us. But there are many more ways that we communicate our potentially communicate a lack of safety or a lack of care to patients that can affect their outcomes. And that this is actually much more common and repeated. So from toxic stress and what we talked about last, or what I shared last week, is that toxic stress and those little, what we call microaggressions, so consider like micro transgressions of boundaries, can add up to something very severe. So if someone was very brutally sexually assaulted in one instance, that can have the same kind of physiologic effect as someone who has experienced microaggressions, microtransgressions all of their lives, but hasn't experienced that one incredibly brutal and traumatic event. The same physiologic response can happen from the brain to the rest of the body and affect their health care. And more often than not, we are part of the micro transgressions and aggressions than we are of the very obvious traumatic events. And we can be part of that process that not only triggers those, the ACEs and the trauma, but also reinforces it. That actually helps to perpetuate that toxic stress and the physiologic response that they're having. And how is that going to affect their outcomes? It's going to make them poorer, because that's what we know about ACEs and trauma, is that the more repetitions, the higher number of them, and the more repetitions of the ones that we've experienced means that we will see greater, deeper, poorer outcomes and responses, to our medications and to our treatments in those patients. So we are going to see worsening or refractory responses to cardiovascular in cardiovascular conditions or hypertension or stroke patients when we are part of a process that creates microaggressions and transgressions all the time. And boundaries are the biggest place where we do this all the time. The first part, like I said, part one is just the awareness. Second part, what we're going to do about it. So we'll get to a little bit of that later on this week, early next week. I'll give you more information on that. But I want you, as a starter, to just start thinking about where this happens, how often it happens to you. Personalize it, right? Because it becomes a lot more easy to see when it's happening to us. It's a lot harder for us to recognize what's happening to other people. And I think that that's very clearly evidenced in the way that we talk to each other in the world right now. And also the way that our world has become a little bit more disconnected. So play around with that. It's uncomfortable. I'm asking you to do lots of uncomfortable things every single week. I want you to do this because it's uncomfortable. Make yourself uncomfortable, because that's also what happens to our patients when we don't do our work. They're uncomfortable. And not only that, it shows in their outcomes. So it is really important personally, it's really important professionally, but it's also important quantitatively and qualitatively in our care for us to get better at this and to not actually be the people who perpetuate those transgressions. So now you have your homework. You know what's coming down the pipeline. I will post more stuff for you. Enjoy, if you can say it that way. And as usual, if you guys have any questions, concerns, anything that you want to say, any comments, you're more than welcome to message me, and I'm happy to message you back. Take care.